morning, everyone. My name is Victoria Bennett. I'm the programme lead for an out-of-hospital urgent care programme in NHS England. And I've had the pleasure to work with Bridget and a number of people in this room over the past 18 months as part of an independent care sector programme. So I'm really delighted to be invited today. Thank you. So, this is what everyone is talking about. Or still. These pictures are actually from 2 winters ago. And about 4 years ago, during winter, I was General Manager for Urgent Care Services at a reasonably sized acute trust. And every day I wanted to know, how many A&E breaches did we have yesterday? I wanted to know how many ambulances are queuing right now. How many A&E cubicles have I got free? And more importantly, how many beds do we have? And it's known that bed capacity, bed occupancy, is a key determinant for A&E performance. And we know that the delayed transfers of care, or DTOC figures, which are commonly talked about in the press as well as at ministerial level. We know that some of that data is flawed, but we do know that it's a good indicator of where things are going wrong. Because if we can't get discharge right, then not only can we not care properly for the people who are sitting in those beds, who should be at home, but we also can't care for the people who are waiting in the ambulances. There's also the big question about why are these people in ambulances waiting to come to A&E? Where has the system failed them, potentially, in terms of their avoidable admission? So, the Urgent and Emergency Care Review was undertaken a couple of years ago now, and it published in 2013 its results, and is currently in implementation phase. And it has a number of aims. It says that we must provide highly responsive, effective and personalised services outside of hospital. We must deliver care in or as close to people's homes as possible, minimising disruption and inconvenience for patients and their families. And for those with more serious and life-threatening illnesses, they should be expected to be treated in centres with the very best expertise and facilities. And as part of this review, we're trying to channel shift. So we're trying to move people from the red end on the right to the blue end on the left. We're trying to intervene much, much earlier in their healthcare needs. And we call this channel shift. And not only is this better for people and their families, it's also better for the health and care system. So the out-of-hospital urgent care programme in NHS England was formed around 18 months ago and aimed to bring together a number of programmes of work that were looking at out-of-hospital care. And it also included some new programmes of work that we knew we weren't focusing on. The programme work streams that we have, just for context, I'll very quickly whiz through. We have a work stream on community pharmacy and urgent dental care. We have another on integrated urgent care, which is the new NHS 111. We also have a work stream on digital urgent emergency care, which is mainly supporting the 111 commissioning standards implementation. We have our independent care sector programme, which I'll talk about on the next slide. And we also have a brand new work stream, which started around 7 weeks ago, around community services, community health services and hospital discharge. And as you can see from those 5 work streams, they overlap so much. And that's part of my job and my team's job, to make sure that there is some coordination and that the leaders are speaking and working together. So the independent care sector programme came from a number of different interventions, but it was known that the NHS weren't really talking to the independent care sector, not properly. And so this programme really tries to get together both NHS and the independent care sector, that's home care, as well as care homes and housing, to meet together and to co-produce work. And we've got 3 work streams at the moment. We have a better use of care homes group, the better use of care at home work stream that Bridget chairs, and also an enhanced support operational group, which brings together 3 elements of enhanced support that we've been trying to implement this financial year. And I just want to talk a bit about the care at home work stream. We have quite a large work plan across the whole programme, but it's been very much developed at a frontline level. So at the beginning of this year, some of you may have attended some of our better use of care at home workshops. And we had 3 of them across the country. And from that, we tried to canvass ideas for what we could do as a national group to help local systems to work together better. And there have been a number of programmes of work that have been developed on the back of that. In terms of what the programme as a whole has done, we've tried to publish a number of quick guides. So I do have a copy of one here, but they are best looked at online. So that's at www.nhs.uk/quick guides. Please do go. We monitor monthly our download rates. So our oversight group monitors that. So it's really good if you could click on and download as many as you wish. But hopefully there'll be a number there that are particularly relevant for you. Particularly to pick out the better use of care at home, which was one of our first quick guides published around a year ago, which is quite a large suite actually of case studies and examples and principles about how we can include and ensure that home care are pivotal when people go into hospital, and then when they're discharged, ensure that they are kept at home. We also have one on sharing patient information, and I just wanted to flag that one because there are a number of stories across the country that we heard that people had really strange workarounds because they felt that due to IG law, they felt that they couldn't speak with their colleagues about somebody who they were all caring for. So we developed this very quick guide. It was only 2 pages long, so I think it's our quickest. And what that aims to do is just to give frontline staff a really quick age memoir so that you know whether or not you can talk about something with another colleague. And we're also planning to update that, which I'll talk about in a second. There's also the Discharge to Assess quick guide. This was going to be the Home First quick guide, but as some of the models are also intermediate care, bed-based, we needed to make it a bit more generic, but that is the principle. How do we get people home before we start looking at things like money and who pays? How do we ensure that care is delivered to people as soon as they need it at home, rather than waiting in a bed in hospital? And there's also, last week we published our most recent quick guide, which was around health and housing. So our programme deliverables, as I suggested, are quite numerous. I won't go through our whole work programme. But I just wanted to touch on the enhanced support package that we've got, just so that you're aware of what's happening. And the first one is our work around care sector forums. And we've just engaged with a supplier, and we're delighted that the UK Homecare Association, as well as Care England and the Registered Nursing Home Association are part of that. And what that aims to do is, first of all, to scope care sector forums. How many forums are in existence? And then to look at best practice. But what we really want is to look at how we can ensure that at a local level, the right people are meeting to discuss operational issues and how to make services better, how to improve services for the people that they all care for. And we see this vision as across health and social care, and directly including the independent care sector providers as well as commissioners. We've also got some work with the Emergency Care Improvement Programme. They are part of NHS Improvement, and what they aim to do is look at challenged health economies, those where the ambulances really are queuing most days. And as part of their work, we've tried to support them so that they can really ensure that people are implementing our quick guides and seeing how people are taking them up as well. And we've also got a regional independent care sector lead now in each of our NHS England regions, of which there are 4. And that just ensures that somebody is wearing that hat. I don't think anybody needs to be convinced that it's the right thing to do for us all to work collaboratively. But at a local level, there are so many pressures that people can take their eye off the ball. And so having these leads in our regions has been really welcomed and really useful for commissioners and system planners. So just a bit of an update about what's coming soon. Quite a big list to do over the next couple of months. But the one that I just did want to flag is that we're about to publish a diagnostic review about a home care in hospital model. And we know that this happens informally across the country in pockets. And we're really keen to see whether this is a model that we need to explore more seriously. And so when this comes out, and I'm sure you'll get it through your networks, please do have a look at it, please do respond. There are a number of questions that we ask, and we'd be really delighted to hear from you. So just as I come to the end, I just wanted to give some levers to you so that you know what you can use to speak to health colleagues locally. And the first one I wanted to speak about was STPs, our Sustainability and Transformation Plans. There are 44 geographies across the country. Plans have been completed by the end of October, but I'm sure there will be further iterations. These are mainly chaired by CCGs, our clinical commissioning groups, but in some cases it's the local authority that chair, and others the acute trust. And I wanted to flag that as part of the age memoirs that were published for the STPs a couple of months ago, which are on the NHS England website, the one for urgent emergency care stipulates that STPs should be working collaboratively with their independent care sector colleagues, and that it explicitly says care home, home care and housing.
I don't want to waste anybody's time, but could we just have a quick look at how many of you have actually been involved in discussions around any STP, Sustainability and Transformation Plan? Any providers? 1, 2, 3, 4.
And we've asked in lots of cases.
Yeah. So I think Victoria already has the message, but that reinforces it.
Yes, and I suppose I mention it because I'm fully aware that this is the case. And I suppose I just wanted to make sure that you had the lever, that it's in black and white about why it is that they do need to work with you. There are lots of other people who also feel ignored, and for that it is disappointing. But I just wanted to kind of give you the pinpoint, the thing that you could use to say, well, actually, it says here that you should be engaging with us. Better care fund plans. Again, I'm sure if we did a show of hands across the room about people who were engaged with their local better care fund plans, it may be as small as STPs. I suppose the difficulty with this is that a lot of places don't actually call it their better care fund plan, they call it something else. So that makes it a little bit more tricky to know where this sits. But I just wanted to mention, in terms of linkages, obviously all better care fund plans need to have a that's Delayed Transfers of Care Reduction Plan for this year, 16-17. And that's where you can obviously be a very vital ingredient. And with clinical commissioning groups, I wanted to flag a couple of levers again that could be used if approaching CCGs, and that is one of their quality premiums. So this accounts for 17% of their quality premium, which is worth to them £5 per head of population. And one of them is around ensuring that continuing healthcare packages are taken less in are taken up less in the acute setting, so therefore at home, which again it is where you can be a vital ingredient to ensuring that can take place. And it also I also wanted to flag around A&E delivery boards. So, not to go into too much detail, but there's now an A&E improvement plan, and as part of that delivery, there are A&E delivery boards. You may or may not have heard of SRGs, System Resilience Groups, which have now been transformed into A&E delivery boards. And as part of that, they've been told that they need to implement discharge to assess models. Again, Homecare is pivotal to those models working successfully. Thinking about NHS providers here and in the main acute trusts, that they have sequins, which are commissioning for quality and innovation. These are worth up to 2.5% value of their contract. And of the 13 indicators for 16-17, one of them is supporting proactive and safe discharge, so that people go back to their usual place of residence. And I also wanted to flag that there is a similar discharge sequin that has just been published for next year as well. And would encourage you to speak with your NHS providers to ask how you can support the delivery of that. I just wanted to, I'm sure most people in the room know this, but this is one of my favourite pieces of research, because Homecare is a vital ingredient for patients, because 10 days in hospital leads to the equivalent of 10 years ageing in the muscles of people over 80. That can be the difference between them being able to stand up unaided or not, and could be the difference when they're assessed about whether they can go home or not. And that is one of the key drivers about why we have to reduce length of stay in hospital and why we have to get discharge right. There is an issue with unsafe discharges. We know that people sometimes are discharged too early, but on the whole, the main issue is that they are discharged too late. And there is quite good evidence to support this fact. And I also wanted to end with this piece of evidence. And this is from a piece of academic research that was done across a number of, back then, PCTs, primary care trusts, which were commissioning organisations for the NHS. And they looked at 10 systems. 5 of them had managed over the previous 18 months to 2 years to either reduce or keep static their non-elective admission rates. And the other 5 had deteriorated in their performance and non-elective admission rates had increased. And they did a lot of research across these 10 patches to understand the services that may or may not have been available in each locality that were preventing non-elective admissions. But interestingly, their evidence didn't find that it was the services available that made the biggest difference. And this is what they said. The most striking differences between improving and deteriorating sites were not the presence or absence of specific services, but overwhelming differences in leadership, culture, and strategic development at the whole system level, characterised by strong, stable leadership, a shared vision and strategy, and common values across the system. I believe that collaboration is absolutely vital for us to ensure that the health and care system into the future can really provide the best quality care for the people of this country. And I'm really glad that there's a piece of evidence that can support that. Thank you very much. Happy to take any questions.
Thank you, Victoria, and thank you also for all the work you're doing with NHS England to try and open things up for collaboration. It's very much appreciated. Again, I think just time for one question. I know Victoria's going to be with us over the coffee break, but then you have to go, don't you? Max, can you say who you are, please, Max?
Max, excuse me, Max Worth from City and County Healthcare Group and HCA Board. It's very interesting to hear all of this stuff, and I think you would have got the sense from people in the room that it sounds great, but the conversations are not happening at a local level. If you were a home care provider, some of us will be one branch operation, some will be much larger. But if you were a local home care provider, what one thing would you do to engage in conversation with health about what you can actually do to address some of this stuff?
One thing. Gosh. I may be biased because of my background, because I'm not a commissioner by background, I'm a provider by background. I would say speak to the discharge teams and whoever leads the discharge teams in the local hospital. And because when I was a general manager, I really didn't know. Oh gosh. I'm sorry, I've said something incorrect.
Most of the acute units are now, the discharge teams don't have much to do with placing. It's the people like care seekers, Grace, it's the placement agencies that are involved in placing people. And the discharge teams rarely respond to anything that we come up with. Living care is a really good example of how you can get people out of hospital quickly if it's robustly managed, proper KPIs in place, and it will reduce the delayed transfers, but there is nobody that can listen to it. There isn't a facility locally, and it has to come from a national, top-down initiative to try and make this happen.
I wonder if I could... Sorry, do you want to answer that? Because I was going to bring in Mike Potts in a moment. Apologies, Mike, I should have introduced you at the beginning. Mike Potts is the co-opted member of UKHCA's board and was one of the key authors of the originating report, I think, Mike. And you may well have an answer to Max's question too.
I'm not sure whether I've got an answer. I was co-opted onto the board to try and help the board think about how they can engage better with the NHS. So my background is I've been in the NHS for 40 years, and I led the Helping People Home team, which did the original report about delayed transfers of care back in 2015. The question I was going to ask is, sustainability and transformation plans are really crucial going forward. And I'm not asking you because I'm sure you won't be able to answer the question, but I'm saying the question to make a point. If I looked at all 44 of those sustainability and transformation plans, how prominent would transformation of the home care sector be? We've all talked about how important it is, but for me, if it's not in those sustainability and transformation plans, it ain't going to happen. So really my point is, and maybe the takeaway for you, Victoria, is when those plans are being assessed, if there isn't evidence of engagement and effective engagement with the sector, what will happen? Will they be sent back for further work? And the person up here said there needs to be some pressure coming down from above to make this happen. That's exactly right, because if the pressure isn't coming down from above, it won't happen locally. But it is back to, you've got system leadership on there. It is down to system leadership at the end of the day. But my concern is around the STPs at the moment and them being signed off, and where is there evidence that there's been real engagement with the sector and what that transformation looks like going forward.
Thanks, Mike. In terms of the sustainability and transformation plans, we have asked if we can see them. Because I totally agree, because there's a number of programmes of work that we know will not feature much in STPs. And we feel like it's really important. So I know that I'm in NHS England, but I'm internally trying to ensure that something does happen, and I think it's a really helpful point. I'm conscious that I haven't really given the one thing that people could do, so apologies. But I suppose depending on the organisation you're trying to tackle, just to say that actually of the 44 STPs, I don't know whether you're aware that the contact details of all the chairs are online. So you could potentially directly approach an STP chair if you feel that the engagement hasn't been appropriate, but you may have already done that, so I may be telling you to do something you've already tried. But I suppose that it's at the acute trust. I suppose I should have said it was maybe not the discharge team, but those who are in charge of it. So usually it would be the general manager for urgent care or the chief operating officer. Again, all their contact details should be available on your acute trust's website. But they would be the key people to target.
Thank you very much, Victoria. I think you've also given us a number of levers in terms of the guidance that's being issued to NHS England people as well, and I think it's up to us to use those levers. UKHCA will be involved in approaching a small number of the STP leads to actually try and push this home, and we have some working with us, so I'm a little bit hopeful, but...
And I suppose we should say that Bridget and I and others are in the process of looking at what we're going to do for the next 2 years, 18 months as part of the programme. So, everything that you'll say today, obviously Bridget can bring to the table, and it will inform our work plan going after from April next year onwards.